Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
All right, here we go. So this is our update. These are my disclosures. We're going to talk about this trial first. This was the prospect trial. So many of us in the room contributed to it. I know at UC Irvine we contributed 18 patients to this very large phase 3 clinical trial of preoperative chemotherapy with selective chemoradiation versus chemoradiation for locally advanced rectal cancer. Now, I mean, one of the key things to remember in interpreting these data is the timing of this study. This study was launched from 2012 to 2018. So, you know, we've moved so much in rectal cancer towards a different standard of care that the control arm here just has to be put into context of when this trial was launched, which was developed in 2011 and launched in 2012. So the randomized schema is shown here. This was standard of care at the time, pelvic chemoradiation, followed by usually a 8 to 12 week wait, followed by TME-based surgery, followed by adjuvant chemo with FOLFOX or CAPOX. In this study, patients with T2N1 or T3 N negative, N0, or T3N1, so basically stage 3 non-N2 rectal cancer patients, were enrolled to that control arm versus perioperative FOLFOX for 6 cycles, and then they had the safety valve to let patients that were not responding go on to receive pelvic radiation if they didn't respond to FOLFOX. All patients went to surgery, and then adjuvant chemo was as per the investigator, CAPOX or FOLFOX. And these were the inclusion criteria. Again, stage 3 patients, excluding those with more than 4 lymph nodes, which is N2 disease, patients who needed radiation, and then also patients that were a candidate for surgery. This is a surgical trial. This is an important thing to remember in context with all the watch and wait trials. We have exclusionary criteria with those requiring an APR, and those with T4 tumors or N2 disease, as I mentioned. The prospect study endpoints are listed here. Disease-free survival was the primary endpoint, and they had a host of secondary endpoints which we'll go through, and importantly, they had clinician-related outcomes and patient-reported outcomes for toxicity. That was felt to be super important for this type of trial, which is really looking to see if we can eliminate chemoradiation from a subset of patients, and radiation is known to have a number of toxicities: ureteral stenosis, infertility, sexual dysfunction, and whatnot. And I like this slide. This was the investigators' kind of a theoretical construct about what they hope to see at the end of the study. This was a non-inferiority design where the hazard ratio could not exceed 1.29. And this is not data. This is just a conceptual study showing if you have FOLFOX and selective chemoradiation better, superiority, your estimate would look like that with 95% confidence limits. Non-inferiority, it would overlap. Not proven would be going beyond the 1.29 cutoff mark, and then inferiority is shown there too. So just keep that in mind when we look at the data. And here we go. Here's the first slide with data. Over 1,100 patients were randomized. You see here was basically a young population. Median age is 57. About 63% were male, 65% over the whole cohort. And then you can see these are really mid-rectal tumors. These are not low. Low tumors were excluded. So these are mid-rectal, and staging is indicated below. Most did have node-positive disease, N1. And this is the primary endpoint. Disease-free survival between the two groups was very similar, 80.8% in the peri-op FOLFOX with selective chemoradiation versus 78.6% in the chemoradiation arm. And so the authors with this, you see the 95% confident limit bounds goes from 0.74 to 1.14. It did not exceed their threshold of 1.29. So they determined this to be non-inferior. And this is just looking at, again, the non-inferiority results, whether they were adjusted or not adjusted for some minor differences in age and nodal status. It didn't make much of a difference. So to commend the authors, they did meet their primary endpoint. They report on freedom from local recurrence, which is important when you think about radiation and how radiation came to be in the first place. There's no difference here, 98% in both arms, free from local recurrence. And overall survival, also similar. Looking at the surgical and pathologic endpoints, path CR was 22% in the FOLFOX perioperative arm and 24%, so really not a big difference. We know with TNT, we expect estimates higher than that, like 38% in the original timing trial. So, but this is, I think, important information. Positive radial margin is a rare event and also not a concern giving perioperative FOLFOX based on these data. I found this slide to be one of the most interesting, or just most important, because we didn't know before designing this trial what percent of those people would need that safety valve to go down to chemoradiation in the perioperative FOLFOX arm, and it was only 9%, so 53 out of the 580 patients needed that chemoradiation, or they just didn't tolerate FOLFOX, and so I think that's a really important finding. It shows that most patients can be treated with this perioperative FOLFOX approach, and the selective chemoradiation is pretty rare, actually. Patient-reported outcomes are shown here during neoadjuvant treatment. It's kind of what you would expect with neuropathy and fatigue and maybe more nausea in the perioperative FOLFOX arm. More diarrhea in the chemoradiation arm, as you would expect. 12 months later is interesting. I can't explain this very well, but there was 8% versus 3%, so a little bit more neuropathy in the chemoradiation arm. So still have to think about how much FOLFOX these patients had after surgery. It's not immediately obvious to me. The quality of life evaluation, well, while numerically superior, there's no difference in quality of life between the two arms, but if you look at the male sexual dysfunction and female sexual dysfunction, those are both improved if we can omit radiation. That was really the driver of this study. So I'm showing you a non-inferiority study. Yes, outcomes are just as good, but we've omitted radiation and we've done some good on the patient outcome side. So this is really my take on the abstract. I would say many non-low T2N1, T3N0, and T3N1 rectal cancers may be considered for this perioperative chemotherapy with selective radiation approach. Sparing patients from some of the side effects we know is due to radiation therapy. The caveats are this: it doesn't apply to low-lying tumors or T4 tumors. It doesn't apply to N2 patients. And also that control arm, it's not really relevant today. We treat with TNT, which has a higher path CR rate. And so this doesn't mean that we can just emit radiation for everybody. I would remind you, we watch and wait. When we do watch and wait, that requires radiation. We cannot do perioperative FOLFOX and then expect to watch and wait these patients. That wouldn't be safe outside the clinical setting, clinical trial setting. So with that, I just wanted to show this other abstract. This is from the Oprah trial. We contributed patients to this trial and to the timing trial, which was its predecessor. This is Julio Garcia Aguilar's study at MSK. And they presented some long-term follow-up data. It's abstract 3520. And I want to put these in context with the last, the Prospect trial, and then where we are today. So if you remember, the Oprah trial was really focused on organ preservation, and it showed that patients can be treated with TNT and avoid surgery, basically. But follow-up was short. So here was the design of that phase 2 trial. Patients were randomized to receive either chemo first, followed by chemoradiation, or chemoradiation first, followed by chemo. And a lot of times you get frustrated by the randomized phase 2B design, but in this situation, it really did show you kind of the value of that approach, because you would expect both would be very similar. Patients had either FOLFOX, CAPOX, and standard chemo RADs, and tumor restaging was done 8 to 12 weeks after TNT. So what they reported was here, 74% of their patients were offered watch and wait, which is really incredible. So these were patients with any stage 2, stage 3 disease, and also much lower, requiring APR without this treatment. 36% developed a regrowth, but that number was higher in the induction chemo arm versus the consolidation chemo arm. And so what those results looked like here, the organ preservation rate was statistically significant here. Those people who had chemo radiation first, followed by chemo, actually had the best outcomes in terms of organ preservation. It didn't make a difference in terms of PFS or overall survival, but still it's pretty interesting from a phase 2 study. So I would say, you know, what's the impact on practice? These data definitely support the use of non-operative management in select stage 2 and stage 3 rectal cancer patients. And it's going to be further elucidated in this, which is the Janus trial in MMR proficient patients, basically adding more chemo to the regimen, but still looking at the same basic design. Now, the elephant standing in the room is this. Last year at ASCO, we heard the update from Dr. Sursek and the authors at MSK on dostarlimab in rectal cancer patients, where 12 patients were treated. All of them avoided chemo, radiation, and they avoided surgery. And to this date, as of the last follow-up, they're all still in complete remission. So everything we just talked about, Prospect and OPRA, it really doesn't apply to MSI high patients. We should kind of focus our thinking of those trials in the context of MMR proficient. And where the Rectal Cancer Task Force is going now, we have this trial ongoing, EA-2201. It's enrolled 14 patients out of 31, small trial, looking at ipi-nivo plus or minus radiation with a chance for watch and wait on this study. So with that, I think that, rectal cancer has evolved a lot. We're avoiding radiation, we're avoiding surgery. In some instances, we're avoiding chemotherapy. And so it really comes down to a personalized decision with each of our patients.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.